ENT Head and Neck Institute, Burjil Medical City. This is our building. That's our logo for the head and neck. This is our clinic. We're in the 3rd floor of the Burjil Medical City. So quite a quick sort of introduction to departments of ENT. If you look at the 5 senses God has given us, nature has given us, we deal with 3 of those. Sense of smell, sense of taste, sense of hearing. Vision and touch are related, but we are a little away from it. We deal with all patients right from newborns till the very elderly.
Dr. Sheikh, if I can stop you there,
Yep.
I'm here.
Yep.
If you can speak closer to the microphone because
Yep.
it's quite
Okay.
loud, and if you'd like to get some more clarity, you can use the headsets to give you a direct feed of the mics.
Sure. In looking at the various subspecialties of ENT, the technical name nowadays is otorhinolaryngology and head and neck services. So it includes otology, rhinology, laryngology, including the phonetics, sense of the voice. Then the head and neck, which is typically the cancer work, both cancer, non-cancer, lumps and bumps, the pediatric airways and the facial plastics. So we deal with all of these here. This is our scope of services. So we have just broken it down for otology, neuro-otology, because we are in the interface between the ear and the skull. The rhinology, head and neck services, laryngology, pediatric, and some of these are our subspecialties which are not commonly done in most of the usual places. So, I mean, it's no need to go through all of these details. They're here to self-explanatory. But let's look at a few examples of what we think we do a little bit differently, or the services which are not available in other parts. Apart from routine middle ear surgery, we look at the specialized middle ear surgery and the advanced ones, specifically looking at implantable aids and the cochlear implants. We also look after the dizzy patients with tinnitus, and we will be opening our state-of-the-art vertigo lab very, very soon in Burjil Medical. This will be probably the only dedicated thing in probably most of the country. Let's look at this funny thing. How can we make this ear work? How can we get the sound across when there is no ear canal? What we see on the outside is just the pinna for the shape, but it needs to have a canal, it needs to have the eardrum, it needs to have the ossicles to work. So these things can come on one-sided, like the picture on the left, or it can be both sides. So how does this child work? So if you look at the hearing, this child probably has a normal nerve, but we cannot get the sound across. The one on the left is just funny-shaped ear pinna, but it also has a normal, very narrow canal. And the one here has a normal looking pinna, but 0 canal. So to get this to work, first, obviously, we look at the hearing status, make sure that the nerve works inside. We scan image to make sure the inner ear structures are normal. Then initially we start with what's called a soft band. There is a hearing aid, which we stick very close to the mastoid bone, where the sound can be transmitted to the bone. This is one of the unique organs where you can bypass, directly stimulate the receptor organ, which is the cochlea, and we hear absolutely normally. We are struggling to do that in the eyes, but this is a structure which is amazingly wonderful. We have the 2 bands on the left side, or 2 brands, and this here, it's just like a sticker. You put it on the back of the mastoid bone and it still can give the sound. But we can't be living with this forever. Yes, the child grows bigger, you cannot be having a band. So we actually image them when they come to a certain age, that's usually 4 years, where the skull has certain thickness. Then we map where can we put this implant, and we actually implant the hearing aid into the bone under the skin. There's 2 different brands. I know we're not promoting brands, but this is the concept of this. So they can be screwed to the bone of the skull, very close to the ear, and the sound is transmitted. And the sound is actually transmitted from outside. It's picked up by this processor, and through the skin, it actually goes and stimulates, and the child can hear normally. This is a similar concept to cochlear implant, but cochlear implant, the actual electrode goes into the cochlea. It happens for people who have a sensory neural loss, and we provide both of these in Burjil Medical City. Just to showcase this video came from a very, very grateful father and parents. This is our first cochlear implant child done in Burjil Medical City. As you know, I've been there about 7 months now. So this is the first one which we did. It's only 5 months. And if I can get the video to work, sorry, I wish I can go back. The child is actually speaking. This was a 14-month child who had some hearing, and then lost because of ototoxic medications. So implanted within 5 months, he's got quite a significant amount of hearing back, and because he had some hearing before, he can actually translate those sounds, and that was the actual, the video didn't work, but he's actually speaking. So I'm going to quickly pause and let my colleague Dr. Yogesh speak about the rhinology and the head and neck services. Then we're going to quickly talk about the advanced pediatric services that we offer.
Thank you so much. So I'm just going to quickly brief on the rhinology, sinus surgery, thyroid parathyroid center. So we did this center in collaboration with the Kansas University in the United States. It's a public university, and this is the first kind of collaboration we are having in the Middle East, where we are a dedicated center, comprehensive for all the thyroid, parathyroid disorders, including the medical and the surgical management. So I'm going to brief on that. We do skull-based surgeries. In thyroid, parathyroid, we are doing endoscopic surgeries. We also have the choice of having a robotic surgery for thyroid in the neck. So, yeah. Yeah, so we're just going to get started. So that's our institute which Dr. Basha introduced. I'll briefly touch on the sinuses endoscopic surgeries as well as the thyroid parathyroid surgeries. So as you all know that allergies, sinus issues are pretty common, and along with the medical management we have the newer treatment choices which include allergy, immunology, immunotherapy and biologics. Again, pediatric sinus surgery is not that common. You can see the disorders can be completely cleared through an endoscope with a fantastic results. But yes, pediatric advanced sinus surgery is one of our scope of services. Another case where it was very close to the eye, as you can see over here, and that was again done endoscopically. This is a lady with a tumor in the nose, completely excised from the nose through an endoscope. So you can see the extent of the tumor, and despite the surgery, she's absolutely normal. So very good cosmetic results. We do have neuronavigation, where a computer and a stereotactic navigation system is attached to the patient, and this tells us that we are able to clear the disease. Going forward, for thousands of years, human has known that nose is an approach. So in the ancient Egypt, they used to do this to clear the brain from the mummies. Moving forward, all this, we have gone through these things where we had a lot of PCRs done. You'll be surprised that we got a case where a child had a PCR done and the swab stick actually injured his brain. You can see over here exactly how it happened. He presented with CSF leak. The brain was kind of damaged. So what we recommend is, instead of shooting up towards the brain, the PCR swab should be done down towards the floor. Moving to head and neck surgery, another case of a carotid body tumor. These are vascular tumors in the neck. We did through a neck approach. It's a pretty advanced surgery where you have to split the tissue between the carotids. So we have everything available. Another case where it's a parapharyngeal tumor in the young boy. We could get it out from his mouth, and as you can see over here, it's a small scar from the mouth. It's almost a 6 centimeter lesion. We removed transorally. Another case, the standard parotid surgery, but what we are doing is, if you can look here, the incision is behind the ear, so they are really hidden well. Moving to the parathyroid, we all know that calcium, vitamin D problems are pretty common, but parathyroid itself is quite undiagnosed, misdiagnosed, undertreated. If these conditions are not treated, you will end up with a bone damage. And obviously in surgery for hyperparathyroidism, we have all the latest advances, which include neuromonitoring, autofluorescence. As you can see here, this is a kind of a gamma camera which lights up the involved gland. But the most important is to find an experienced surgeon. So despite having all the technologies, if you don't have an experienced surgeon, it might be in trouble. So we have all these facilities in our institute. We are doing endoscopic parathyroid, we are doing endoscopic thyroid surgeries as well. As you can see here, the scar outcomes are excellent. Moving forward, we have these tumors for parathyroid, which are again very rare. Going back to the thyroid, probably the most common condition faced by the females. And you'll be surprised to know that thyroid is the second most common cancer right now in UAE. So it is pretty common. It's just after breast cancer. And again, 100 years back, this is how thyroid surgeries were done. And the entire patient was put in an airbag to reduce bleeding. But then obviously, thanks today, we have all the latest technologies that we have available in our facilities. We do have laser treatment of thyroids. We are doing it regularly. We have minimally invasive thyroid done through a small incision. The outcomes are fantastic. As you can see here, almost like no scar in the neck. And then going back to extensive thyroid tumors, we do have robotic thyroid surgeries. This is done at Kansas University. This was almost in 2012, about 12 years back. We have an established robotic program at Burj Al Institute. And going back to Kansas University, this is one of the top 10 medical centers in the United States. More than 72 million NIH granting, and one of the best institutes. We have these collaborations. These are the directors who are associated with our program at Burj Al Medical City. And again, a very comprehensive setup of the Head and Neck Institute, including the thyroid, parathyroid. So I'm going to give it to Dr. Basha, who will continue with his presentation.
Thank you for waiting, and we're just waiting for the next. We're just going to quickly show you our approach for the pediatrics, because this is not a well-known branch of ENT, and most of the times parents and the public are not aware to say, like, we didn't know these things happen. The child has breathing problems. How is it managed? So, in the pediatric AVS services, these are complex children who have breathing problems right from birth or later, which they develop. So it says, the saying is, it takes a village to manage this. So you're going to need all of these type of people, and including a most advanced, experienced intensive care team. So that was our first aerodigestive clinic that we had started a few months back. That includes a pediatric pulmonologist, gastroenterologist, because when we are born, all these are common organs, the pharynx, and then it separates into the swallowing areas and the breathing areas. So if you're born with one problem, you're born with other problems. Most of these can be quite complex syndromic children, or you can have a normal child with one deficiency which leads to the problem. Commonly children land in the ICU again and again because they tend to choke, they tend to aspirate, which is commonly not diagnosed. So it needs all of the specialties, speech and language, respiratory therapies, intensive care, neurologists to look after this. So let's look at a few rare conditions, as I said, which are, so foreign bodies we all know. Child swallows, gets coin stuck, child also inhales, and certain things are stuck inside. So you can actually see one side of the lung being hyperinflated. So I wish the videos work, but the first one you can actually see, that's a bronchoscopy. The difficulty with this approach is the anesthesiologist does not put a tube in. So we are sharing the airway. The child is deep, but he's still breathing, but he's not conscious. So that's a very difficult plane to achieve. In this, we manipulate, go and find it diagnostically, take it off, and quite often it's not one; it's multiple pieces stuck inside the lungs, inside the bronchi. Sometimes it is solid bone stuck high up in the larynx, which was quite not diagnosed. Took many hours to come from a peripheral center to us. We deal with the commonest breathing problems is laryngomalacia, small child, premature or not, but breathing problems right from the beginning. So the epiglottis, which is a very floppy cartilage, is more floppier, and different stages of it, you breathe in and it sort of collapses. So this is a diagnostic challenge. You diagnose and deal with the appropriate how we manage, which part of the larynx, so they can be divided into various stages and manage this. And this service is what we do, and this is one of the probably commonest one. Just to highlight, this is how it is. You sort of laser off part of the skin or the mucosa and open up the epiglottis so the child, it does not collapse into it. These are one of the difficult ones where you have a big cyst in the back of the epiglottis, back of the tongue, and you cannot even intubate. This, if you see the video, how difficult it is. For the anesthesia, it's a nightmare because you burst it and it lands up. These are a lot of common cases. Yeah, you can probably see this. This is, you can see the uvula. People are struggling to see what is happening, why is this child struggling around. And then with great difficulty, you can actually see how the epiglottis is. We are dealing with a lot of laryngeal stenosis. This can be primary or people who have had trauma to the larynx, injuries and scarring and foreign bodies batteries. So how we laser these, you can see on the scan, that's the scar process. You cannot intubate and child cannot breathe. You laser, you balloon them and make the breathing better. There's also tracheal stenosis. Now we have 3 children, unfortunately had surgeries and traumas from Gaza, 3 in the past 2 months that we had to go and dilate the tracheal parts. You can see that's the bronchoscopy showing which part of the trachea is stuck, and that starts lasering and ballooning this. We deal with children with facial deformities right at birth. This child has bilateral corneal atresia and born with a lot of deformities that we have to go find the skull base and open up the cornea and fix this. This sad child came from one of the Emirates, massive tongue because of an hemangioma, extremely difficult to intubate, extremely difficult to manage, and had ASD, has Down syndrome, because cannot intubate, cannot have his cardiac expertise done. So initially we remove the lymphangioma, put in a tracheostomy, secure the airway, then go back and deal with the tongue. Massive tongue, you can't even close the mouth. So with the tongue reduction procedures, still maintain the functionality of the tongue. He can still dip it up and touch, so his sense of speech is okay. This is one of the very, very rare ones to manage this. This child was born with a very, very long stenotic trachea. He was born with this. So there's no way you can intubate these children. There's no way. So we do this procedure called slide tracheoplasty. These children are put in a bypass. You open up the chest, you separate off the trachea, you cut it into 2, and actually double barrel this. She's actually 6.5 and comes completely normally. So this is the top of the range in terms of the top of the pyramid in terms of what is the most advanced. There are very few centers in the world actually do this. This is our second child with the same problem. Fortunately, she's finished her first birthday. The parents very thankfully sent to say, look, she's still alive. She came from one of the centers in Dubai. They just could not manage, and so that's her trachea. It's actually a few millimeters in size. So that's a 3D print of the trachea. We use that to map up how do we manage and how do we do calcium. And that's her. They actually moved from Dubai, live next to the hospital, to say we can't get these services somewhere else in the UAE. We are very advanced in our fetal medicine, and probably some of you must have seen what the presentations are on day 1. One of our recent cases was a child with congenital diaphragmatic hernia. Diaphragm is not formed, so all the organs, the lungs are not there when we are born. They grow as we grow. So if there is a big hole, all the intestine comes up, the liver comes up, heart's pushed to the side, lungs don't get a chance to grow. So we actually go at 24 weeks, identify, go down to the trachea, put in a balloon through a fetoscope. This is all intrauterine. So that balloon swells up, and then lungs, all the fluid the lungs produces gets a chance to open up. So, and then we go back at 32 weeks and remove the balloon. So this allows the lungs to open, and then when the child is born, we go back and patch it up. So this is a combination of fetal medicine, ENT, and intensive care, and the pediatric surgery. So this kid had a exit at the stage 2, that is at 32, 33 weeks. Exit is this. It's I wish I can go back. Yes, it's ex utero intrapartum. So it is before as the child is being born, child comes out of the uterus but not fully born. Okay, and then we secure the airway. We go in. I'll show you a classic example which was done. So this was a child with, as you can see, this is the metal MRI, this is the head, this is the spine, and we can actually see that's a huge big tumor on the neck. The chances of being born normally without trauma to the mother, 0, child surviving a normal delivery, 0. You can deliver this with a cesarean, but how can you manage the airway? This is just sort of stuck with a huge tumor in the neck. So these procedures are raw. We just had a series of pictures. You do a controlled section, you paralyze the uterus so it does not contract, you get out the head. This is the head, this is the neck, and that's the tumor. So it's far bigger than the head. So with the child still half in, with the placenta control, we intubate the child. We get the hand out, we get this line. So we are secure in terms of full anesthesia. There's an intubation, there's an airway control, then you have an IV access, then you deliver the baby. So this is called an exit. This was the kid, massive size tumor, which is 990 grams, so it's like 25% of the body weight. So we image to see how big it is, where it is coming. So that's the size of the mass that it had come out. That's the kid at 5 weeks. That's him at 5 months of coming back. He's 4.5, 5 years of age now. But we have 7 of these so far. So I think it's very rare to have a center getting so many, or the same team getting so many of these in one place. So This was just in brief to highlight the various kind of cases that we are doing. It's not possible to talk about all the range in this time, but thank you for your patience.
Thank you for all the attendees, and thank you for both the doctors. If you've got any particular questions, you can raise your hands and I'll bring the microphone over to you to address the questions. If there aren't any, we'll quickly move on to our next presentation. Thank you very much for both of you doctors for joining us today. Thank you.